Good evening, ladies and gentlemen. Welcome to our second Tempo conversation on hyperlipidemia or cholesterol. My name is Jacqueline Lowe, and I'm the team leader in our wellness department. Thank you for taking the time to attend this session, and I trust that you will find the session informative. Our speaker will present for about 45 minutes, and we will have questions and answers afterwards. You are welcome to ask your question in the chat box during the presentation, and Sister Tandi will address your questions after the presentation. And you are also welcome to raise your hand should you wish to ask your question. It is my privilege to introduce our guest speaker for tonight. She is Sister Tandi Bukali. Tandi is an occupational health nurse practitioner with over 15 years within the public and private sector. She has devoted herself to the study of unique, scientifically sound solutions to modern health issues. Over and above her occupational health and nursing qualification, she holds a PMB qualification from GIBS, currently a MPhil international business candidate at GIBS as well, and a member of Toastmasters International. Through nature of work, she does have co-partnered with a number of corporates to offer wellness education across the landscape and has been able to coach scores of audiences with her passion for wellness. Tandi is the General Manager of Specialized Clinical Services Division and a member of the Executive Committee at a Gauteng-based private health and wellness organization. Welcome, Sister Tandi. We look forward to your presentation.
Thank you so much, Jacqueline, for that warm welcome. We are so delighted to have all of you join us tonight for our discussion. And we hope it is fruitful, and we hope that it is as informative as possible. If it even helps us to change one life at a go, would really even appreciate that. So I'm going to go straight into the presentation so that we use the time wisely and make sure that we still have some time left for questions, because I believe that if we engage, that's where we can be able to assess whether the information was fruitful or not. And that's where we can be able to gauge whether we managed to reach all of you or not. So I'm going to switch off my video just for a proper bandwidth, and so that I don't get cut off frequently, and then we'll go ahead with the presentation. Okay. Okay, so as part of my preparation for this presentation, I was recently reading a book by John Saney, his very recent publication. The book is about who do we become. Basically, it focuses on the changing eras and changing dynamics that we're faced with as life evolves, and the certain cycles in our lives basically come across. And he mentions quite a few things that people should think of when they discover or want to work on who their future selves would look like. It is certainly the same sentiment when it comes to health-related situations or health-related matters. Food, lifestyle, and a whole host of things that form the core components of our culture and our heritage, somehow, somewhere end up becoming the ingredients to what predisposes us to certain health conditions. And, you end up having to weigh your options as to what comprises, the food stock you have in your pantry versus what you could no longer have. So indeed, that message hit home for me, because we don't really just consider who do we become externally, but we consider that on many other levels of our lives as well. So for our topic tonight, we are going to talk about hyperlipidemia as well as cholesterol. And I'm hoping that at the end of the session, you'll be able to discover and fully, establish where do you stand in terms of this particular subject, the risks, the management plans, your journey into changing your life around if you've already been counted as one of the people that suffer from the conditions, or if you know someone that suffers from the condition. Right. So what is hyperlipidemia? Our bodies basically are made up of quite a few constituencies. There is a certain percentage of water that makes up our body composition. There is sugar, which we normally call it glucose. There are certain salts that form part of our body. There are gases, there are fats. All of these are required to be present in our body in certain numbers or certain ranges. Once they are more than what they are required to be, we often use the word hyper to indicate that it's above the limitation or the range that particular substance is supposed to be. Once they are lesser than what they are required to be, we normally use the word hypo, which means basically lesser than the required level. In terms of hyperlipidemia, it is taken from the word lipids, fats, as I indicated earlier on. So this is a situation where inside your blood vessels, the lipids or the fats that are required to basically form certain cells within those blood vessels are produced in large numbers due to a number of factors. And when they are produced in large numbers, your blood vessels can no longer contain all of that which is flowing within there. These fat particles end up being embedded on the walls of your blood vessels, and they will end up creating, a decreased lumen, or basically a decreased passageway for your blood and everything that needs to flow in your blood vessels to flow properly. This restriction will make you exposed basically to other conditions like heart attack and stroke. You would remember when we were discussing hypertension, we said it is the pressure that your blood vessels experiences in terms of being able to have a good or proper blood flow. So the two are very closely related, as you would have remembered when I mentioned this, if you were with us in our previous Tempo talk. And the biggest thing about this is that there is no way, unlike with high blood pressure and the other conditions, where we can say, look out for a headache, look out for blurred vision, look out for the following signs and symptoms. It also follows a very close narrative of being a silent killer, because literally it is very difficult to pick up symptoms if you do not or have not had a blood test, either a rapid finger prick test done or a blood test sample drawn from your arm to be tested at the lab. So it is a silent killer times 2, basically. So these are the examples of how your blood vessels would look like, with the top artery or top vessel basically looking normal with all the constituencies that are required in that particular artery or blood vessels. Then you get to see the second one, where this plaque or this excessive fat has started attaching on the walls of the blood vessels, and it's starting to form a plaque. And then later on, you start to see this plaque starting to form a clot, basically, because the blood cannot pass in time through that passageway, and the longer it stays between that narrowed passageway, it starts to become a clot, which will later result into a stroke or into a heart attack, depending on which blood vessel, blood artery is affected in the body. If it is a blood vessel or a blood artery that is closer to your organ like a heart, then you would know that that would basically be the situation. But it depends on where that clot lands. And that's where we'll then end up with the eventuality of either a heart attack or a stroke. So now, who could be at risk, just as you think about this conundrum that we've just explained? There's quite a few things that we can consider in terms of who is predisposed basically to this particular condition, from the young to the eldest, male and female, and so forth and so on. And the risk categories, when you look at them, they are almost a match, an apple for apple, with what we discussed when we're talking about hypertension. People who are obese are more predisposed to this particular condition. And here by obesity, I'm referring to people who are generously proportioned at certain areas of their body, particularly around the chest and waist. This is where the bad fat basically sits, and this is where we get exposed to cardiovascular related condition. A sedentary lifestyle, we mentioned this in the previous talk as well. Smoking, family history, alcohol use, those are just some of the lifestyle kind of habits that one needs to think about. When you think about health conditions, people who would be exposed here are people who are already diagnosed with one of the types of diabetes mellitus, which is your sugar-related condition, as well as people who are on treatment for HIV. Some of the ARVs tend to lead to a syndrome where they basically harbor more fat around the waist more than they ordinarily would, and a few other treatment regimens that they would be put on may predispose them to this particular condition. The type of food we eat, it appears as if food will be part of every conversation we have around health-related issues. In this particular category, the type of food we're talking about is food that is made up of saturated fats or high trans fats, as they would call it. So those kind of foods exposes your body to this particular condition. Smoking, particularly because the effect of nicotine, as I said previously, it constricts your blood vessels. So if there's already some exposure of some progression in terms of this condition forming inside your blood vessels or blood arteries, that constriction predisposes you to the worst effects quicker than it would have been in a case where there is no smoking in the history. When you speak about family history here, there is a particular type of hyperlipidemia or high elevated levels of cholesterol that we find that is related to genes. You find that you're not obese, you are an active person, you don't have any other health conditions, you eat well, you don't smoke, you're good in age, but you find that you have this issue. There is a condition that forms part of the genes from that we basically inherit from our families. Also, one thing that I also want to mention around diet, we are getting more and more people, with the recent years that are changing the mode of diet from the normal staple diets that we know of to either vegan or keto-based kind of diets and so forth and so on. Based on what those diets are composed of, there could be other factors that one may have to have a look at, which is why it's important to utilize your benefits from Bestmed and have a chat with the dietitian before you change or before you adopt any other diet. And maybe lastly and not least, age and gender. Age particularly, it's the same rule that applies everywhere. We know that anything that has more mileage requires more savers. So I'll just leave it at that in terms of age, but our bodies degenerate to some extent and they no longer do what they used to do when we were younger. Gender, I will share a few slides on how this particular issue of gender is coming in when it comes to risk categories, right? Now, the incidence and prevalence rate, the numbers here are very difficult to come to basically a very clear, good picture that's easy to understand. But the trend analysis that has been done and picked up as studies were done does give us an indication of where exactly could we be sitting or what we could basically have a look at, right? We discovered that with studies that are done globally, this condition is more prevalent, or the incidence rate is high in female than in males, basically. And you would think of a few things already here: the diet, the sedentary works life style, the obesity, and a few other things that could easily come in the category of females versus in the category of males. What is important to note there, though, is that the mortality rate is quite higher in males because males often delay seeking health-related services. So they sit with a condition and will only really seek medical help if it affects a certain function, that they treasure, or a certain ability, that they treasure, and only then. And most of the times you find that by the time they come in for help, it is often too late, right? We know that non-communicable diseases are the leading cause of death and disability in South Africa, even worldwide. So hyperlipidemia, your hypertension, all those conditions that basically lead to these kind of conditions are attributed to here. Worldwide, we are told that this condition amounts to or attributes to the 2.6 million of deaths that we see annually. And it's also one of the key contributors to major cardiovascular events, as I mentioned, heart attacks, as well as a stroke, basically. We have a program that we do for executives here at Health Impact, and we have seen the numbers. We can attest basically to the last blue point there in terms of what happens. There was a study that was done recently in the beginning of the year, if I'm not mistaken, and it's published on a science report. This study took a group of about 600 middle-aged people who were staying in urban areas, some of them already being treated for some comorbidity or another. And then they did a study to try and check the prevalence and the patterns around hyperlipidemia. This study was done in South Africa, right? As you can see here, the blue represents the type of condition, basically the presence or the absence of this condition. In some publications or some books, you'll find that hyperlipidemia is listed as dyslipidemia. So this is basically still the same topic that we're talking about, but it just basically means the abnormality in the lipids or the fats that we need to have in our bodies. It was discovered that basically male versus females, you can see that in males, dyslipidemia was quite high, on some certain aspects. And then in the females, the numbers are even higher. When you compare the two, there's the abnormalities that were picked up there. And then on the right part of the slide, we're just basically breaking down as to who had the highest abnormal numbers amongst the compositions of your cholesterol levels or your lipids, basically. And I'll just go to this shortly when I go to our diagnosis in terms of what does this mean. You can see that your female counterparts were already presenting with a high number of values, high values in terms of total cholesterol. They were showing up with high values in terms of low cholesterol there and high LDL, as well as the triglycerides. These patterns are feeding back to that information that was telling us that females are more basically predisposed than males. These are the age groups that this study was being done on. And when you have a look at who formed part of those age groups, you can see in blue, female participants were more than males. And then in terms of the split in years there, and then you can see that in the first top left, we were looking at the total cholesterol, and then the breakdown basically of the 4 components that I mentioned before closing off that particular slide. But all of these components are showing us that in this particular study, it affirms what the other authors and what the other researchers have picked up, that basically the condition is more common in males, in females than in males, right? So now, if you find yourself in a situation, and if you've already quickly gone through the risk categories that I've mentioned, and you've probably ticked and quickly scribbled 3 or 4 things that you think applies to you, if you go to your medical practitioner, these are some of the things that will be done. They will unpack your health history in detail because they want to know, basically what other conditions could be there. They don't want to isolatedly treat this one condition that you have walked through the door, you know, showing interest on. That is at least the approach that we always use. We want to look at the situation holistically, main focus on what you're complaining of and everything that relates to that. So they'll do a health history and just find out, ask a number of questions around that. Have you had an operation? Do you use contraceptives? Are you on any treatment? Are you taking any multivitamin? A whole host of questions that can be asked basically to come to this. There's also what we call biometric screening. You'd remember previously, I did say when there's hypertension, we already are on the lookout for possibilities of you acquiring diabetes mellitus, which is your sugar. We'll also look out on the possibilities of you acquiring lipid-related conditions. So in this biometric screening, they'll probably do a BP reading for you. They'll quickly do a random blood sugar sample for you, and then they'll do a finger prick, cholesterol test for you, just to basically see what is happening. On the finger prick test, you will get a reading of a total cholesterol. I'll just explain that in the next slide. However, if they are to send you over to a lab to have a blood test there, it will basically do the components that are reflected on the right part of the slide. And family history as well, that I mentioned earlier on, this will form critical part of the questions that will come up in the assessment that will be done. We do see that some medication that people get prescribed to use also does have a side effect of affecting how your blood flow and how your vessels works basically, and end up putting you in a situation where you basically have hyperlipidemia. And most of the things that I have really listed here, or 2 of the 4 that I listed here as examples, form part of your hypertension treatment, if you would remember, right? So now the blood sample has been sent to the lab and it is coming back and you are ready to get your results. These are the critical numbers that we would love to see and that we will base our interventions on. HDL is basically defined as your good cholesterol. This number must be high. You can even remind yourself by renaming it and say HDL with H meaning high, because you want that number to be high. And if that number is high, it basically gives you a better option in terms of how the total outlook of your lipid profile is, right? Your LDL would be named as the bad cholesterol, and these are the values that we are particularly looking at. And there are certain actions and interventions that apply to each category in terms of these numbers and in terms of these results that you would get alongside the entire history and profile that you would have put on the table, right? So this is basically what we could be looking at in terms of numbers. I won't go through the numbers in detail, but I'll just flash it up here and I will share the presentation so that you can have a look at the numbers and then see where you basically stand, and you can be able to relate to the information that we have here. But basically, these are the categories that we have in terms of your readings or the results that will basically come back. And as I would have said, if your numbers are sitting at desirable levels, then we know basically what type of recommendations we give you. Continue exercising, continue doing the following, continue eating well, continue taking care of yourself in this particular manner and that particular manner. If you are on borderline, please come back and see us in a year, 2 years, 3 years, depending on what the profile looks like. If you are on the high risk category, then we know alongside all the other recommendations, there should be talks on starting you on treatment if there is no other way of correcting the situation, basically. Right. So I've just spoken about management or treatment options briefly as I was closing off on that slide. When you think about non-pharmacological management actions, I always break the two into two groups because you want to focus on what is it that I can do without medication, or what is it that I can do over and above taking medication. I was intrigued basically to see that in April, Bestmed was already hunting and pumping this topic around lipidemia and a few things that members can do and benefit from doing, like these following steps here. You have to fill in that lifestyle questionnaire, have your blood pressure checked. There are few things that I really mentioned on the other side. So I don't know whose job am I already taking here by applying to be Bestmed's PR person, but I saw this and I thought, yes, this is good. And it's very, clear, and it really is it's an easy to follow guide. So these are some of the things you can do. And as you'd remember, for those who attended the previous talk, I always basically encourage people to start having a conversation. Even if you don't know where to start, just start by having the conversation. Start by getting a screening done, and you will know where to start from there. And then the conversation will end up leading you to what you should be doing, right? If obviously you fall on the other categories that I mentioned when I was showing you that slide with the results on borderline as well as high risk, and treatment already has to be included in your management plan, there are quite a few groups of treatment options or regimens that can be introduced to help you manage the situation. And remember, the reasoning behind treatment or pharmacological kind of approaches is to try reverse what is already happening in the body, try reducing the chances that what is happening and resulting in an abnormality doesn't happen. It's to try and act against anything else that facilitates that abnormal process in the body. So these groups of regimens are basically prescribed for different people, as you would have seen. The different types of lipids as well that we were dealing with, they would definitely need a different type of approach as well. The most common one is the statins, the group that forms, that is made up of statins. The most common a treatment you can think of there is simvastatin and a whole lot of others. These help lower the bad cholesterol by making sure that the liver doesn't produce this type of cholesterol, and it increases the ability of the liver to remove this cholesterol that is already in the blood. So that is how it basically counteracts the process. The bile acid and sequestrants, they remove cholesterol as well and remove bile acids. Bile acids are often produced to assist our blood vessels in producing their cholesterol that will produce their blood cells in our body. So by counteracting that effect, that is how your cholesterol can be also controlled. There is also the niacins. Here you can even get this in form of, they do form part of some other supplements in very small quantities, and they come in the form of vitamin B, and they improve all your lipoprotein levels, which are able to facilitate proper production of right kind of amounts of lipids in the body. There's also the group that falls under nicotinic acids. These also increase your high density cholesterol, the good cholesterol that I was talking about, and then it suppresses the other cholesterols that we do not want to see. As you would have seen in the previous slide, to get to your high density level cholesterol, you would basically need to combine the numbers between these other two components of your cholesterols. I'll go back to that slide if we do have time, just so that you can see how that is basically calculated. You also have your fibrates that will lower your triglycerides. You also have your injectable medication, which is more common on the cholesterol that I mentioned that comes from family-related risk factors that has to deal with our genes, basically, that we get from our families, right? We don't only inherit money from family peers, we inherit a whole host of other things, right? So one has to choose carefully. Cool. So now what happens then if it happens that you have not been able to pick up this condition in time, if it has been picked up but you're not adhering to treatment, or if it has been picked up but because of some complication or another, your body is not responding to the treatment that you are put on, you will end up with a long list of complications, one or two amongst these. As I mentioned, heart attack is one of the most common because this is a very lethal and a very, I don't know how to put it besides saying that it's silent killer times two. There's a lot of damage that it does in your body without you feeling it and without you knowing it. We end up in stroke. There could be coronary heart disease. These are just types of other heart diseases that can happen, but basically it's a very fatal eventuality should it happen that there's a complication that arises from this condition and it's not treated on time. Now, I had a look at one of the publications by Dieter Veldsman. He used to work for Momentum, but he works for another company now in Netherlands, and it's called My HR Academy. And they were looking at future skills that HR-related people want to develop. And I am relating to this because I know some of you on this call are either managers, you either report to someone, you either have a whole host of people that you are leading, and you know someone who is responsible for other people. And I often find that, in a platform like this to really address that particular type of a target group also helps, because these conversations hardly happen in our boardrooms. They hardly happen in other spaces where we meet as managers and as ordinary people and employees. So in this particular research, it was discovered that most HR personnel wanted to develop the following skills in no particular order. Most people wanted to develop their people analytics skills, their soft skills, the ability to strategically work and manage their workforces, as well as digital HR on the latter end of this list. And this is critical, and it's said to me the need that these people showed and indicated that they wanted to develop was basically based on some of the things that they saw happening within their organizations or within their places of work or wherever that they're exposed with people. Being able to manage people around you has become so critical because we realize that half of the risk factors that I was speaking about, the demographics around females, the age group that I was referring to, half of those people, if not more than that, are in our workspaces. And if we do not have, a tentacle of ways of managing them, it is easy for us as employers, as managers, as colleagues, and as employees to end up losing a loved one. And I'm mentioning this because, again, it is clear that this condition is lethal, and at any given point, without any warning, someone who was healthy yesterday, who appeared healthy yesterday, can end up with stroke today. They can end up with a heart attack today. And if they end up with stroke or any other complications that I mentioned, definitely it now speaks to your sick leave. It now speaks to an employee who is at work, who can no longer function as they used to function before. And you now have to figure out a way, how do you productively and cost effectively manage them at work? And I see this over and over and over again as we assist our clients in terms of navigating through managing employees who are either coming at work with some level of presenteeism because of an unmanaged health condition, or who are presenting with absenteeism because of the frequency that they have to be away from work in terms of trying to manage this particular condition. And in closing, we could see that on some of the factors that I mentioned there, lifestyle, diet-related factors, and chronic stress are some of the key exacerbating factors of hyperlipidemia, amongst a whole host of others that I mentioned. And it would be irresponsible if we work with with people or manage people without considering these in our day-to-day lives, and making sure that there is a way we can help someone start a conversation of having a look at these critical numbers, improve a conversation of having them manage their conditions better, as well as also just generally take care of our organizations by making sure that we can strategically manage our workforce properly, applying all sorts of relevant soft skills, people management skills, whilst we are still wearing our hats of basically driving business strategy on the other hand. And I think this is the last slide on my side, but I would like to encourage you to go on the Bestmed portal and really navigate through and see, based on your medical aid option or cover, which of the other benefits you can get. And we encourage incentivized behavior. So there's quite a whole lot of things that you can benefit by just going out there and getting these numbers checked out. Jacqueline, I'm going to hand over to you just to have a look if we've got any questions so that we can deal with that and take it from there.
Thank you so much, Sister Thandi. It was really informative, and thank you for sharing your knowledge with us. So far, I've got 3 questions. The first one is from Stacy. She asked, do you need to not eat and drink the night before your cholesterol test?
So there are 2 types of tests that could be done. On a basic screening, you do the very first one that you do, we call it random cholesterol test. You can have this one at a clinic. It's a finger prick test one. You don't even have to fast. You can have it at any time, just like you do with sugar and the other tests. However, if it happens that this particular test is abnormal in terms of the ranges that I was showing you earlier on, then you definitely will be requested to have a blood sample taken that will be sent to the lab. This particular blood sample, then you will be required to fast the night before you eat. You have it done. I'm already thinking about food. I saw eat somewhere there.
Okay. And then Stacy asked again, how long does it take to correct your cholesterol with just changing your diet?
Okay, so Stacey, there's quite a whole lot of things to consider here. Remember, we would have to start by looking at the entire profile. Are you just presenting with this cholesterol that you are trying to correct? Alongside that, are there other family-related issues? Like, was it basically born from the gene factor that I was speaking about earlier on? Are you from a big boned family? Because that would then relate to your obesity and BMI issues on the other end. Are you dealing with stress on the other side? Are you also active just over and above, sticking to a right kind of diet? For instance, for a person who has a lower BMI, who has already, adopted a very active lifestyle, who does not smoke, does not engage in all the other components that I mentioned when I was talking about risk factors. Diet, just correcting the diet. We do see people coming to test this month, changing and modifying their diet accordingly and coming to test the following month, and the numbers look completely different. So there is no prescribed number or turnaround time that I can give you for this, but you'd have to consider the picture as a whole.
Thank you. The next question, does the removal of a gallbladder cause an elevated HDL?
Here as well, there would be a few things to consider. To some extent, even though there is no extensive research that's done around this, you would remember I was speaking about the treatment that is based on bile acid earlier on. So some of this function could be affected when your gallbladder is removed. It would also depend, the severity of your elevated HDL might depend on what was your condition like before even having the operation and afterwards. But if you are experiencing that particular symptom, it is always good to have a proper chat with your clinician so that you can be able to, put the finger on the right causative factor there.
Okay. Lynette Spencer asks, what is your take on people who follow a ketogenic lifestyle?
Okay, so I'm going to probably say this answer hush hush because my boss is on a very high keto kind of like he's a hyper on ketogenic lifestyle. And he has given us a few talks here and there on how your cholesterol basically gets affected when you start, especially in the beginning. You know, there is some impact that it has to your numbers. And as I was speaking earlier on about diet, I had advised that it's always better to have a chat with your dietitian. I think this also ends your points here at Bestmed. Chat with your dietitian and see how does your basically how does your profile looks like, and should you change to all these other newly found diets like banting and all the others, how does that basically affect your profile, because most of them are very high in fat as well.
Okay. And then the last question I've got here is from Brioni. She asked, if on medication, can you take a break from the medication if your numbers are good?
So a break will only be prescribed by your doctor who put you on the medication. I do know that the approach that we often use is to rather wean you off from medication than to completely give you a break or have an abrupt stop. Because as we see your risk profile reducing and improving, we want to make sure that we steadily adjust the scale, and you don't want to immediately remove something and the scale at an exponential rate tilts to the other side. So I do know that they will first wean you off. Say, for instance, if you are on a combination of 3 or 4 types of medication, including other things, they'll start reducing. They'll keep the same medication because it's working, but reduce the dosage depending on which tier of dosage you were in terms of that medication, all the way down up until your clinician is comfortable to play around basically you having medication on certain odd days to a point where you do not have medication at all. However, with the recent spike in COVID-19 cases that we saw almost 2 years ago, all the way up to where we are now, most people have been encouraged. You would remember even at the peak of COVID-19, as soon as you are diagnosed with COVID-19, some of the cholesterol-related kind of drugs that we often see, some of them would be included there to basically fight against possibilities of forming clots in your blood vessels. So there are habits that you shouldn't really get rid of, and there are those that can be modified, but it would be really a fallacy for me to say, oh yes, stop the medication from here, I'll be arrested. Yeah, cool.
Thank you so much. Okay, is there any other questions that you want to ask Sister Thandi? While you're thinking, if you want to, I just want to remind you that on the Tempo program, and it's available on all of our options, you've got once a year, you have a health assessment that we pay for. It comes from your preventative care benefit, and you can go to any Dis-Chem or Clicks pharmacy and have the nurse take your biometric screenings, and then that unlocks your 3 consultations with a Tempo dietitian and a Tempo biokineticist. And again, we pay for those 3 consultations with each. It's not paid from your savings or your day-to-day benefits. So if you have any questions regarding that, please send us an email at tempo@bestmed.co.za. And you see, there comes another question. I'm on simvastatin and was advised that it's better to stay on same as palliative care rather than take myself off it.
Absolutely, absolutely. And as you would know, and I think perhaps the particular respondent was also advised to basically stay on, or perhaps adjust a few things separately. But simvastatin is not harmful. It is given sometimes as a prophylactic part of prophylactic treatment before people go on an operation or before a certain procedure is done. So really, it's one of the most most common and one of the most effective drug that can be used.
Okay. And then another question, does having had COVID affect your cholesterol levels at all?
So I would rather attend to this question the other way around. You know, the impact of COVID if you already have cholesterol. As I mentioned earlier on, in some kind of cases that we would see that, you know, because of restricted blood flow and a few other things that happen when a person has the COVID virus, there was a high incidence of people presenting with blood clots. And if you already have cholesterol, a formation of a blood clot basically is now leading you 3 steps ahead from where you were, and you are more predisposed to a cardiac event earlier than before. However, as to whether COVID you know, lead to an elevated cholesterol, that would be really difficult to answer by TAMSAC. But I do know that, you know, when you have those comorbidities and then you have cholesterol, you have COVID-19, then definitely your situations become a little bit dire.
Okay. It seems that is all the questions. We will have the presentation available to send to you afterwards should you be interested. So if you've got any questions or if you want to have the presentation, please send an email to tempo@bestmed.co.za. And then I think that is that. So I just want to thank you, Sister Tandi, and thank you to each member who attended this session. We really appreciate that you take the time to attend this. And then I hope that we can see you next month. Our conversation for next month is breast cancer. So we will send out the invitations to you all. So just keep an eye on that. And with that, have a lovely evening further and talk soon.
Awesome. Thank you so much, everyone, for your time. I really appreciate the engagement.